aortic tear or anything to that is going to be very dangerous. And then the vena cava is the giant vein that all other veins empty into. So again, a ton of blood. And if you damage your vena cava, that is also very dangerous because you can lose quite a bit of blood. So those will come up, the aorta and the vena cava. You want to know where they are and kind of what could maybe damage them. So if you have someone with massive trauma to the chest or to the back, especially if it's penetrating, you want to be concerned for large vessel injuries like that, like to the aorta or the vena cava, because they're so big that they can tear and you can lose a lot of blood. All right, these are the components of blood. I would imagine we've heard of white blood cells from Magic School Bus or somewhere else. Red blood cells, platelets, plasma. I'm gonna go with you wanna stop bleeding, and most of these are not going to be discussed on the mountain. The only thing I can think of is if you have a traumatic injury, why would it be a problem if someone has a traumatic injury and they take aspirin every day? Has anyone heard of this?
Yeah, go ahead.
Blood thinner, doesn't clot.
Yes, exactly. So aspirin is a blood thinner. It keeps your blood from clotting. So if you have a traumatic injury in your head or anywhere else in your body and you're on blood thinners, that will make it much easier for that injury to bleed and to keep bleeding than someone who's not on blood thinners. So we do ask people if they've had a traumatic injury and we're concerned about a bleed, you want to ask them, are you taking blood thinners? Because that could make something maybe moderately serious, that could make it be treated in a very serious, very cautious way because you want to be extra careful. So like sometimes if there's enough suspicion, like an older person who takes a lot of blood thinners, even if they have a ground level fall and they maybe kind of bumped their head, but they're not sure, and they're a little bit shaky and confused, that might be an ALS transport just because they're on blood thinners and you can't be sure that they're not bleeding in their brain. So it kind of affects your decision, like how safe is this person? Like, are they likely to be bleeding or not? If you know they're on blood thinners, that ups your suspicion. It makes you a little more cautious. And that's because it is an antiplatelet agent. It inhibits the platelets from clotting your blood.
But if you took some aspirin, for example, the night before, and you took 2 aspirins because, let's say, you had too much wine, and the next day you want to have, does that is considered as, is it a blood thinner? An aspirin is a blood thinner if you take it once, or is it a blood thinner if you take it often?
Yeah, actually, this is an interesting one. Aspirin lasts 7 to 10 days because aspirin is an irreversible inhibitor of your platelets. So if you take aspirin once and you take a reasonably sized dose, it will inhibit all of your platelets and you will not be up to normal clotting capacity until 7 to 10 days have passed, because that's how long it takes for your body to make new platelets. So like they won't let people go into surgery if they've had aspirin within 7 to 10 days. So that's used in hospitals pretty frequently. That's the time they give for aspirin to wear off, is a full week at least. For something like ibuprofen or Advil, which is a similar drug, but it's reversible. So it does not need 7 to 10 days to reverse its effects. So like that would be something where if you took it yesterday, you're probably fine the next day. So that's like the scientific answer, is it depends on the drugs, because all drugs are different. But I would say the really cautious EMS answer is probably if your patient has had blood thinners in the last few days and they tell you about that, you should just assume they're blood thinned. Just assume it out of abundance of caution. I would say that would probably be the best practical way to handle that. Is if they report any history of blood thinners, just act like they're on blood thinners now.
You guys carry clotting agents?
No, we do not. That's we don't carry hemostatic agents, or like we don't do any injectable drugs. So nothing like heparin reversal or like platelet agents. But even clotting agents, we just do stop the bleed. Like Patty said, there's an algorithm where you go with pressure with a small dressing, pressure with a large dressing, tourniquet. At no point in our treatment algorithm do we have hemostatic agents like powder or bandages. It's just not built into our protocol by our protocol director. And I don't know that we've ever felt the need for them. I don't know that we feel it would change patient care all that much. An interesting question though. I think like I actually asked someone about that at some EMS conference, and they said the biggest application for those is in the military, where you have just like massive traumatic bleeds that need to be stopped immediately, and you're going to have difficulty controlling them even with a tourniquet, like a full limb amputation from an explosive device. He said that is like what you need hemostatic powder for. He said short of that, it's really not going to make that much of a difference above just pressure and a tourniquet.
Okay.
And also when you have a patient in that state, they will be heloed out.
Yeah.
So the quicker you get them off the mountain, the more you save.
All right, we're talking about white blood cells. White blood cells defend against infection. That's all we really need there. Platelets, we talked about, form clots to stop bleeding. Plasma is the part of blood that is not cells. It's just like this fluid that all the cells float in. Not much to be said about it. All right, so this is the order of blood flow I was talking about. Like I said, I don't know why, but EMS really likes this as a concept. It is an important concept in medicine, absolutely. I would recommend you take some time on your own to familiarize yourself. I'm not just going to keep listing it here. I don't think that would help anyone learn it. But just recognize that there is a set order that all blood has to go through the heart. So it has to start at one point, and that's the intake at the vena cava, the giant blue vessel that you see dumping the blood into the heart. That starts at the right atrium. And then from there, with each contraction of the heart moves in this predetermined path throughout the rest of the vessels. It goes to the lungs, then back to the heart, then to the body, back to the heart, and it just continues like that. So I would recommend going and studying the order of the chambers of the heart and the lungs and the body that the blood flows in. All right, again, this is just that order. That's something that you're gonna need to study on your own to memorize. We talked about the capillaries are the narrowest blood vessels. So this is just talking about with the veins going back to the heart. Like we said, the arteries have more pressure than the veins. So what the veins need to move blood back to the heart, because they don't benefit from that pumping action. They're so far down the chain that they get very little pressure from the actual beat of the heart. So they benefit from muscle contractions, and then also from little valves that keep the blood from flowing backwards into the veins. So that's what helps the veins move the blood back to the heart, is movement of your body. And when your muscles contract, it squeezes that blood back into your heart. And has anyone seen varicose veins? I'd imagine we've seen varicose veins on our legs or someone else's legs. If you see a varicose vein, all that is the valves that usually keep the blood from going backwards in that vein so that it goes only one direction, only towards the heart. A varicose vein is a vein that has become stretched out, and the valves are no longer able to prevent the blood from flowing backwards. So it kind of just stays in the vein, and the vein dilates, it stretches out a little more, and it becomes very prominent. So a varicose vein is just an example of what can happen if the valves in your vein were not there. It only happens in those superficial leg veins because they don't have that much muscle contraction to squeeze the blood back. In the veins that are deeper in your body, they won't do that because of the muscle contraction. But that can just help you appreciate how necessary those valves and the muscle contraction is to keeping that blood going back up towards the heart. Because if it wasn't there, you would have those pooling, those giant veins with just pool of blood in them. All right, This is just saying that blood feeds the kidneys and the kidneys make your urine. That they do. A utility of this is just looking at this circulatory system. If you ever have any sort of penetrating trauma to the abdomen, then major bleeding is a serious risk and a serious thing you should be worrying about or concerned about. And this is why, if you look at this circulatory diagram here, there are a ton of huge blood vessels in the abdomen and in the chest. And so that's why if you ever get penetrating trauma to this area, like a tree branch poking or a ski or something, that can cause a lot of bleeding. Or even blunt trauma, just something hitting you there can cause a lot of bleeding in that area. All right, pulse points. So let's all practice taking our pulse. Let's see, I'm gonna go out to camera view here. I hope everyone knows how to take our pulse. We'll go with our first one right here. So we're learning medical speak. This is called our radial pulse. Everyone try and find your radial pulse. That's something you need to get good at for patients. It's a really quick way to just assess someone's heartbeat and how strong their heartbeat is. It gives you a lot of information right there. It looks like Dean has a watch that probably takes his radial pulse for him. So he's not even doing it himself. That's how you work smart. Nice. So radial pulse is going to be right by the thumb. We call it the radial pulse because this bone right here is your radius. It's the bone in your arm on this side. It's called the radius. So the pulse right here is your radial pulse. You should be able to feel it right there. So look around for it on yourself. That is something you'll want to get comfortable with for patients, being able to quickly find their radial pulse because it gives you a really quick assessment of how fast their heart rate is and how strong their heartbeat is. If it feels very weak, that can cause you concern. If it's very fast, that could cause you concern. So it's a really quick way to assess someone. We'll move on to the other, probably second most common pulse. That's going to be your jugular pulse. It's at your jugular vein right here. I think the best way to learn how to do this on other people is just to do it on yourself when you're bored. You know, you can just quickly go to it, be like, where is it? And then you'll get good at doing that on other people. You'll be able to quickly find it. All right, and then the last one, the slide lists a few, but the other one that we actually use is called the dorsal pedal pulse, which means top of the foot. It's called the dorsalis pedis pulse. I mentioned this earlier. It's on the dorsal side of your foot. Everyone can try and find this one. It's kind of difficult. This is the hardest pulse to find, I think, in EMS situations.
100%. Yeah.
Everyone try and find this pulse on the top of your foot. It can be quite difficult. It depends on the person. Yeah, I'm having trouble finding mine even. It takes me a minute. I got it. So why would you want to find this pulse on someone? Why not just take the pulse at the easy points? Why would you have to take the pulse at the foot?
That tells you they have good circulation if it's getting that far.
Yeah, exactly. So if you're worried that someone maybe like broke their ankle or broke their leg and they're not getting circulation to their foot, then you want to make sure that they are getting circulation to their foot. And the way you do that is by finding the pulse in their foot. If you can feel it, that means the blood is getting down there. A really nice thing to do for other EMS personnel, they'll appreciate this. On their ambulance ride, they have to check the pulse every few minutes to make sure that that limb is still getting blood. So if they have a gnarly ankle injury, they're going to check that pulse every few minutes to make sure it's still getting perfused. So if you mark it with like a magic marker or a piece of tape, that they'll appreciate that, because then it's really easy for EMS to find the dorsal pulse every time they go back to it. And if you don't do it, they might just do it in their ambulance. And, you know, a lot of EMS is anticipating someone else's needs, working together with your team. So any opportunity you get is always good. So if you can mark the dorsal pulse for them, they would appreciate that. All right. Uh-huh.
You cannot find it. Where is it?
It's so it's on the top of your foot. It's usually somewhere around it's like right in the middle. If you're looking front to back, it's right in the middle. and you want to look kind of in the space between your big toe and your second toe. It'll be kind of in that area. And then look on either side. It's different in everyone though, which is what makes it so hard to find. Maybe we'll make this one homework so we don't spend too much time on it. But yeah, I encourage y'all to keep looking for it. It's a tricky one. All right, we'll go back here. All right, so if we go to this little diagram, another utility of these pulses, just with your radial pulse, which is the one at your wrist, you can see it labeled here as radial. Your radial pulse will only be present if your blood pressure is at least about 90. So you know a healthy blood pressure is 120/80. If your blood pressure drops to 90/60, you're right at the borderline for being able to feel someone's radial pulse. So this can be a tool where if you come up to someone and you feel for their radial pulse and you can't find it and you don't think it's just you, you think it's really not there, and then you go to their jugular pulse, which you can feel pretty much as long as someone's alive, they'll have a jugular pulse. If you can feel a jugular pulse but not a radial pulse, that means this person has very low blood pressure. It means that the blood has enough pressure to make it to their jugular vein, but not to their radial artery. So that is a concerning sign. So that's another way you can use these really subtle sort of physiology anatomy cues to do a really powerful assessment of someone's actual state of being. So if you don't feel radial pulse, that means their pressure is probably under 90 in the systolic. All right, and here we're talking about blood pressure. We measure blood pressure with two numbers. There's the systolic pulse, which is the top number, or 120. And there's the diastolic pressure, which is the bottom number, or 80 here. So if you see at the bottom, 120/80, 120 is the systolic pulse, 80 is the diastolic pulse. Systolic, it just means systole is what we call it when the heart beats. When the heart muscle squeezes, we call that systole. And so the higher number is the pressure when the heart muscle is squeezing, that's higher. So we call it the systolic pulse. Diastole is when the heart muscle relaxes. So the diastolic pressure is the pressure when the heart is relaxed, and that's going to be lower. So that's why we have the two numbers. All right, nervous system. We're actually making pretty good time. We only got like 10 minutes left, and we should be able to finish this next class, I believe, in not too much time because we've covered most of it. All right, nervous system consists of, and actually, wait, let me see how many slides we got left. Maybe this is just a good natural stopping point. Let me just, there we go. Oh, actually, we got quite a bit left. We're going to keep going. Sorry, y'all. All right. So the nervous system is the most complex body system. It has the brain and all the nerves. We have the central nervous system, which is the brain and spinal cord. You can see it highlighted in that diagram. And the peripheral nervous system, which is all of the nerves on the outside. These are the components of the brain. There are smaller divisions than this, but this is a good one. You have the cerebrum is the large top part, the cerebellum is the mini brain, and the brain stem. Cerebrum is the largest part. This is the part that makes us different from other animals. It's the thinking part, it's the personality part, it's the overriding your animal instincts part, it's the like discipline and don't eat cookies all day every day part. That's what the cerebrum is. That's our human brain. Anyone know what the animal with the largest cerebrum to body ratio is? It is dolphins. It's not humans. Dolphins have a bigger cerebrum to body ratio than humans do. So they might be smarter than us. We don't really know. All right. You have two hemispheres of the brain. They control opposite sides of the body. the right side of your brain controls the left side of your body, and vice versa. And the cerebellum is the balance center of your brain. It coordinates a lot of muscle movements. So any injuries to the back of the head, any injuries to the head really can cause you to have issues with balance and coordination, but especially traumatic injuries to the back of the head, if they manage to damage the cerebellum specifically, you could have serious issues even standing up and coordinating muscle movements. All right, and then the brain stem is the vital function center. So anything you do like breathing or your heartbeat or your digestive system function, those are controlled by your brainstem. They actually cannot happen without it. So if you damage the brainstem, that's going to be the most fatal injuries come from brainstem damage. Anyone know why? So if you get like a bleed in your brain and you get progressively more tired and you get progressively less conscious until eventually you're just in a full-on coma, and then eventually you will die if your brain continues to bleed. Anyone know why it has that sort of progression? So if you look at this picture, if you have a bleed in your brain, it will start at the outside compressing the cortex and everything else, and it'll squeeze in and it'll damage deeper and deeper structures as it keeps squeezing inward until eventually it gets to your brainstem. So the first thing to go is your awareness. You start to get confused, and then eventually your whole consciousness kind of shuts down. The whole outer cortex of your brain that keeps you conscious, that will shut down as it gets compressed. And then eventually that squeezing, that compression reaches your brainstem and it starts to really damage that. And that's what's going to cause you to have serious life-threatening issues and then up to death when that brainstem actually is too damaged to continue working. So that's why any head injuries with bleeds will have this progressive course where people slowly get less conscious because the brain slowly gets squeezed more and more.
Generally, if you came across that, you wouldn't know immediately. I mean, I guess the signs would obviously that you'd be looking out as what you just mentioned right there, the confusion and stuff like that. I mean,
that is a great question. And even to ER doctors, it's one of the most difficult things is to look at someone and say, do you have a bleed in your brain? Sometimes it's very obvious and sometimes it's not obvious at all. And that actually leads to like huge numbers of head scans being used in ERs, like they're overused even. It's very difficult to tell what level of brain damage someone actually has when you're just speaking with them and asking them questions. And we will do a whole chapter on head injuries because that's such a huge topic, especially in at Lee Canyon. But yeah, it's a difficult thing to assess. I'd say
yeah, I would think at the Oh, sorry. Oh, I was going to say,
Yeah,
I think
please.
at the terrain park, I mean, that would, of course, be a major factor if, you know, someone takes a massive fall there.
Yeah. Yeah, no, of course.
I mean, landing on your head is definitely not out of the question. So
yeah, and a lot of people
that'd
out
be
there
like
don't wear
something that would come.
helmets. Yeah, no, it's something that does come up quite a bit, and it's a difficult topic. I think the point I'll put on it now, because we will go over it in depth later on, and you'll learn plenty of like questions to ask that can kind of give you an idea. But I think the important thing is just abundance of caution, because even doctors, when they're put in this situation, like imagine an ER doctor, they get the final word. If they tell someone, yeah, you're fine, you can go home, they'd better be sure that person's not bleeding from their brain, right? And even ER doctors are very cautious there. They will overuse head scans. They will be very careful with not sending people away who should have had a scan and had some sort of intervention to keep them from bleeding. So just knowing that this is something that even challenges doctors at final level of care, I would approach these patients very cautiously and just be very conservative. Like always recommend, if you have any suspicion, say you should go to the hospital and you should get checked out. Don't be cavalier and be like, yeah, you seem okay, I think. Like you just want to be really cautious. I'd say that's the biggest practical point I'd give on this.
So it's always an ALS call for that. Always.
I would say so. I mean, unless they're totally fine and they never had symptoms, their friends like, oh yeah, I saw them bump their head and they're just walking around and they're not complaining, like, then yeah, maybe you say, okay, maybe you should get checked out. But if they are symptomatic at all, if they're like sleepy and they're acting a little funny, I would say I'd call that ALS. They might AMA. We actually see that a good bit. Like they'll sign against medical advice and they'll say, I'll go to the hospital, but I'm not going by ambulance. That I've seen patrons usually want to do that because they feel that like I might have a concussion, but I don't think I'm going to die. So they just want their friend to take them. That is their right. And it's up to you if you want to really strongly push for the ambulance. It's going to be kind of case by case, but that's, again, you'd want to be conservative. And if you think there's anything going on that is serious, I would really push them to be cautious as well. It's a hard call to make.
But Greg, that's when you implement documentation.
Absolutely. Yeah, no, if someone signs AMA with a head injury, like if they deny care, you absolutely want to get their signature. You want to write down, like, I told this person to get in the ambulance and they said, no, I'm fine. Because yeah, that is a sketchy situation when you're telling someone you really need medical attention and they decide to not take it. You want to be very careful there and make sure it's written down exactly what you did. That's a good point.
Just put pressure on their friends that they're responsible for them, and then they'll give them right back to you.
Absolutely, yeah. No, that is with their friends maybe being less cloudy because they didn't hit their heads. That is a huge asset in being like, hey, I think your buddy needs to go to the hospital. They will often help you. That's a great point. All right, with that, we are at the end of our time. Thank you all for your sustained attention. I know it's difficult over Zoom like this. I'm trying to ask questions and keep y'all involved, and I'll keep trying to do that. But yeah, y'all seem to be doing well. You seem to have a good intuition for some of this stuff. So I'm excited for y'all, and we'll keep it rolling next week. Patty, do we have anything else?
Not really. Hopefully, we'll be able to log in on time next week. We're going to master this. And if you have a book, go over it. This will be uploaded to the cloud. And also all the recordings will be. And I'll send out an email how you can get access to it. And then we'll have tests.
Patty, a quick question. So for the Zoom, we should receive for each session an email from you with a link, or we should use always the link you just sent again?
I will send you the information on how you can access everything. Oh, you mean like when the next Zoom meeting?
Yeah.
Yeah.
So use the same exact thing that you went today.
Okay.
And now that I understand how to invite you in, it'll make it a lot easier. Like I said, this is trying. But I really appreciate your patience and everything. And if you have questions, please ask them, write them down, and then we'll address it at the next meeting. How's that sound?
Thank
Okay.
you.
All right. That is stuff to study, by the way, y'all. They pack a lot into this little survey of anatomy and phys, so make sure you go take a look at it on your own. It's hard to cover here. So yeah, but thank you for working.
Thanks.
Thank you.
Good job, Greg.
Thanks, Greg.
Yeah, thank you. You made it very, very easy to understand.